Say, let's define what clinical utility is, and then let's reward value and all agree on what is the bar that we're trying to hit to make sure that we're doing good for patients and their families, and not just creating a lot of cost for hypothesis-driven, purposes, because we can do that in research. But in clinical practice, it has to be different. So while I'm delighted that we've had a huge success in breast cancer, have moved to colon cancer and prostate cancer, we've just really got to do better before I would say, hey, we're really committed to precision medicine, because the map I just outlined wouldn't suggest that we're putting our money where our mouth is as a country.
And I just a couple things. First, this reinforces that what I was just talking about, the need for a Cal Index and the longitudinal patient record, because what happens in the clinical setting is a black box. We know what we pay, but we don't necessarily know what's happening now when the diagnosis happens, when the decision happens. So I can't necessarily go tie payment to, the way that you described, even though I would potentially love to go do that in the right circumstances with the right data set. So I think it's a real key to unlocking all of this is, if we have visibility into that, then the interest in saying, let's try this, and we'll be able to see, here are the inputs, here are the outputs, is the outcome happening or not, and it'll all be visible to everybody.